Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular session, I'll be discussing a very important topic in the cardiology, that is the pulmonary hypertension. So if you see the definition of the pulmonary hypertension, is based on the right heart catheterization measurements, right? It is based on the right heart catheterization measurements. And when is that you will have, when do you consider that there is pulmonary hypertension? It is defined as when the mean pulmonary artery pressure is greater than 25 millimeters of mercury at rest, we call it as the pulmonary hypertension. Okay, so when mean pulmonary artery pressure, when it is more than 25 millimeters of mercury at rest, then we use the word pulmonary hypertension, right? That is when the mean pulmonary artery pressure is more than 25 millimeters of mercury at rest. And a mean pulmonary artery pressure of 20 millimeters of mercury at rest is considered to be normal. Okay, when the mean pulmonary artery pressure, when it is around 20 millimeters of mercury, this is considered to be normal, right? This is considered to be normal. Whereas when the mean pulmonary artery pressure, right? Whereas when the mean pulmonary artery pressure, when it is in between 21 to 24 millimeters of mercury, right? When it is in between 21 to 24 millimeters of mercury at rest, it is considered to have an uncertain clinical implications. Right? It is considered to have an uncertain clinical implications. Okay, so this is the basic definitions of pulmonary hypertension. So when mean pulmonary artery pressure is greater than 25 millimeters of mercury at rest, then we call it as pulmonary hypertension. And when the mean pulmonary artery pressure is 20 millimeters of mercury at rest, it is considered to be normal. And when it is in between 21 to 24, the individual is happen to have uncertain clinical implications. Now, followed by that, let me tell you, in patients with the pulmonary artery hypertension, definitely mean pulmonary arterial pressure should be more than 25 millimeters of mercury. That is a definition. But it should be associated with normal pulmonary capillary wedge pressure, right? But it should be associated with pulmonary capillary wedge pressure of less than 16 millimeters of mercury at rest. That we call it as the pulmonary hypertension. This we call it as primary pulmonary hypertension, right? When there is normal pulmonary capillary wedge pressure, then we consider it to be primary pulmonary hypertension. What is that? I will discuss. And why there should be normal pulmonary capillary wedge pressure also I will discuss. But let me tell you that pulmonary capillary wedge pressure, right? Pulmonary capillary wedge pressure, it is representation of the left atrial pressure. Right? It is the representation of the left atrial pressure. Please remember, that's an important point. Now, you see this question now. Pulmonary hypertension is defined as the pulmonary artery pressure more than 15 millimeters of mercury, 18 millimeters of mercury, 20 millimeters of mercury, 25 millimeters of mercury. So, when the pulmonary artery pressure, when it is more than or equal to 25 millimeters of mercury, we call this as the pulmonary hypertension. Right? We call this as pulmonary hypertension. Now, following that, let me discuss what are the etiologies of pulmonary hypertension. So, at this point, please don't get confused about the pulmonary capillary wedge pressure. So, why the pulmonary capillary wedge pressure should be normal, all that I will discuss. But pulmonary capillary wedge pressure, please remember, it is the representation of the left atrial pressure. And if you see a question here, in primary pulmonary hypertension, basic abnormality in gene lies in bone morphogenic protein receptor 2, endothelin, homeobox gene, PAX11. Now, let me discuss the etiology and then come back to this question. So, there is a classification for pulmonary hypertension, right? And that particular classification is given by the World Health Organization. So, World Health Organization has classified pulmonary hypertension into 5 groups, right? Into 5 groups. So, what are those 5 groups? Number 1, pulmonary arterial hypertension from pulmonary vasculopathy. Right, from pulmonary vasculopathy. And second important, pulmonary hypertension due to left heart disease, right? Pulmonary arterial hypertension from left heart disease. And the third important group is pulmonary arterial hypertension due to lung disease or hypoxia, right? That is from lung disease or hypoxia. And the fourth important group is chronic pulmonary thromboembolism, that is pulmonary arterial hypertension secondary to chronic pulmonary thromboembolism, that is the fourth group. And fifth group will be pulmonary hypertension with unclear multifactorial mechanism, right? Pulmonary arterial hypertension with unclear multifactorial, right? Multifactorial mechanism. So these are the 5 groups of pulmonary arterial hypertension according to the WHO. I will discuss each and every group in detail. So you take group 1, that is pulmonary arterial hypertension from pulmonary vasculopathy. So if you take group 1 pulmonary arterial hypertension, it is related to an underlying pulmonary vasculopathy, right? And this group 1 pulmonary arterial hypertension, previously we used to consider this as primary pulmonary arterial hypertension, right? It includes the former, that is previous primary pulmonary arterial hypertension, or this is also called idiopathic pulmonary hypertension. Right, this is also called idiopathic pulmonary arterial hypertension. Okay, so in these individuals, what exactly is the cause is unknown, right? It is only just predilections that this would be the cause for the development of pulmonary arterial hypertension. And almost like 6 to 10% of causes of group 1 pulmonary arterial hypertension, they are heritable. Right, almost 6 to 10% they have what is called heritable pulmonary arterial hypertension. Now, this heritable pulmonary arterial hypertension, it is due to mutation in bone morphogenetic protein receptor 2. Right, it is due to mutation in the bone morphogenetic protein receptor 2. This is the one which will cause the pulmonary arterial hypertension. Right, which one? The mutation in the bone morphogenetic protein receptor 2. So, like what exactly is this BMPR2? Let me discuss. So, whenever there is mutation in this gene, right? Whenever there is mutation in the BMPR2, that will promote the cell division, right? That will promote the cell division, or it prevents the cell death. Right? It promotes the cell division and it prevents the cell death as well within the pulmonary artery. So once it is promoting the cell division and preventing the cell death, what happens? There will be overgrowth of cells in the small arteries, right? There will be overgrowth of cells in the small arteries, right? And this overgrowth of cells in the small arteries will be there throughout the lungs, right? Throughout the lungs. So thereby, what will happen to your arterial diameter? The arterial diameter it gets narrowed, right? The arterial diameter it gets narrowed. So once the arterial diameter gets narrowed, there will be increased resistance to the blood flow in these arteries. Right? There will be increased resistance to blood flow in these arteries. So thereby, what will happen to the pressure in these pulmonary arteries? The blood pressure or the pressure within this pulmonary artery will be elevated, right? And the same scenario will happen within the pulmonary artery. Right? This particular scenario will be seen in the pulmonary artery, resulting in what is called the development of the pulmonary arterial hypertension. Right? Resulting in what is called as development of pulmonary arterial hypertension. Okay? So, in primary pulmonary hypertension, the basic abnormality in the gene lies in bone morphogenic protein receptor 2. So, because of the mutation of this gene, there will be increase in the cell growth and there will be decrease in the cell death. Now, what are the heritable gene mutations? So I said you like 6 to 10% of group 1 pulmonary arterial hypertension is mainly due to gene mutation. So if you take the heritable gene mutations, that includes, right, that includes BMPR2 gene mutation. Then another important gene mutation is, right, the other important gene mutation is the ALK1. And another important gene mutation is endoglin. Right? Another important gene mutation is endoglin. So these are the heritable gene mutations which are responsible for the development of the pulmonary arterial hypertension. Now, apart from these heritable causes, let me tell you, even there are certain drugs. So drug and toxin induced pulmonary arterial hypertension is also considered in the group 1 pulmonary arterial hypertension. Now, what are those drugs? Right? Exposure of the following drugs are considered definite risk factors for pulmonary arterial hypertension. That includes aminorex, then we have fenfluramine, next we have dexfenfluramine and toxic rapeseed oil. Okay, so these are the drugs. And where do we use this aminorex, fenfluramine and dexfenfluramine? This aminorex, fenfluramine and as well as dexfenfluramine, they are used to reduce the appetite within the individual. Okay, next, Followed by that, in contrast, drugs that are considered likely or possible risk factors for pulmonary arterial hypertension include even the amphetamines. Right, even the amphetamines, they are considered to be the drugs which will cause the pulmonary arterial hypertension. And apart from these drugs, we have certain substances or certain drugs like phenylpropanolamine, then we have L-tryptophan, next we have methamphetamines, next cocaine, and followed by that we have selective serotonin reuptake inhibitors, right, SSRIs. So these are the drugs and substances which will contribute to the development of the pulmonary arterial hypertension. Next, there are certain other etiologies which will cause group 1 pulmonary arterial hypertension. So one is, we have discussed the gene mutation, that is BMPR2 gene mutation, ALK1 gene mutation, and as well as endoglin 1 gene mutation or endoglin gene mutation. And then drugs and as well as toxins. Drugs include aminorex, fenfluramine, dexfenfluramine and toxic rapeseed oil, amphetamines, L-tryptophan, methamphetamines, cocaine, phenylpropanolamine, and as well as selective serotonin reuptake inhibitors. Then we have certain other etiologies as well, right? And these other etiologies include secondary to HIV infection, right? Secondary to HIV infection can contribute to the development of group 1 pulmonary arterial hypertension. Then portal hypertension. Next, congenital heart diseases. Next, we have a parasitic infection, that is schistosomiasis. Next, chronic hemolytic anemia. Right, and then followed by that pulmonary occlusive diseases or pulmonary capillary hemangiomatosis. Right, pulmonary capillary. So these are the etiologies which will cause the group 1 pulmonary arterial hypertension. I mean, apart from your drugs and as well as gene mutations, these are the other causes which can contribute to the development of group 1 pulmonary arterial hypertension. Then coming to your group 2 pulmonary arterial hypertension, you see where exactly you have the pulmonary artery. Now consider this is your 4-chambered heart. This will be the right-sided heart with tricuspid valve. This will be the left-sided heart with mitral valve. So you have the left atrium and then left ventricle, then right atrium and then we have right ventricle. So these are the 4-chambered heart. And from the right ventricle you have the pulmonary artery, right? So this is how the anatomy will not be there, but for just understanding sake. So this will be the pulmonary artery, and here you have the lungs. The pulmonary artery give rise to your pulmonary capillaries, and then the pulmonary capillaries will open into the pulmonary veins. So this will be the pulmonary veins, right? This will be the pulmonary veins. So now you should understand here that whenever there is any left-sided pathology, that is whenever there is left ventricular failure or whenever there is mitral stenosis, the pressure within the pulmonary veins, right, the pressure within the pulmonary veins increases, and subsequently there will be increase in the pressure within the pulmonary capillaries, and subsequently there will be increase in the pressure within the pulmonary arteries. and that will result in what is called pulmonary arterial hypertension. So group 2 pulmonary hypertension, it is owing to left heart disease. Right, it is owing to left heart disease. Okay, and this left heart disease, it could be either a systolic dysfunction or a diastolic dysfunction or a valvular heart disease. Okay, so this left heart disease, either it is systolic dysfunction or it is diastolic dysfunction, or it could be secondary to valvular heart disease. Right, so these are the causes for group 2 pulmonary arterial hypertension. Then followed by that we have group 3 pulmonary arterial hypertension. So what is this group 3 pulmonary arterial hypertension? Group 3 pulmonary arterial hypertension is that owing to lung disease or hypoxemia. Right, owing to lung disease or hypoxemia. So you take any lung pathology. So for the development of the pulmonary arterial hypertension, if there is any pathology in the lung, that will make the individual to develop hypoxia. And whenever there is hypoxia, right, whenever there is hypoxia or hypoxemia, right, this will cause pulmonary artery vasoconstriction. Right, this will cause the pulmonary artery vasoconstriction. So due to this pulmonary artery vasoconstriction, the pressure within the pulmonary artery increases, resulting in what is called pulmonary hypertension. Then followed by that, you take group 4 pulmonary arterial hypertension. See, group 4 pulmonary arterial hypertension is due to pathology within the pulmonary artery itself, and that will be chronic pulmonary thromboembolic disease. Right, chronic pulmonary thromboembolic disease. So now you see what happens here. So if you see the image here, for example, if there is any thrombus, right, if there is any presence of thrombus within the pulmonary artery, what happens? The pressure within the pulmonary artery increases, and that will result in what is called pulmonary hypertension, which is called chronic thromboembolic pulmonary hypertension. So right, so this group includes patients with pulmonary hypertension due to thromboembolic occlusion. Right, so there will be thromboembolic, right, there will be thromboembolic occlusion of the proximal or distal pulmonary vasculature. Right, occlusion of proximal or distal pulmonary vasculature. That will be your group 4 pulmonary arterial hypertension, which is nothing but chronic pulmonary thromboembolic disease. Then followed by that we have group 5 pulmonary hypertension. Group 5 pulmonary hypertension, it's a multi-system condition, or multiple conditions may contribute to the development of the group 5 pulmonary hypertension, out of which we have the hematological disorders, and that hematological disorders include myeloproliferative disorders, then splenectomy will contribute to the development of group 5 pulmonary hypertension. Then you take the systemic disorders. Systemic disorders which will cause group 5 pulmonary hypertension include sarcoidosis, then neurofibromatosis, pulmonary Langerhans cell histiocytosis, right? Pulmonary Langerhans cell histiocytosis, then lymphangioleiomyomatosis, right? Lymphangioleiomyomatosis, and then followed by that we have metabolic disorders, and these metabolic disorders include glycogen storage disorders, and second we have Gaucher's disease, right? And what are the other conditions which will cause pulmonary hypertension? Other conditions include the chronic renal failure on dialysis, and next we have fibrosing mediastinitis. Okay, so these are the causes for group 5 pulmonary arterial hypertension. So now you take group 1, it is pulmonary vasculopathy, and that would be due to gene mutation, that would be secondary to drugs, right? Or that would be to certain underlying etiologies like connective tissue disorders and HIV infection. Group 2 is the cardiac pathology, group 3 is the lung pathology, group 4 is thromboembolic disease, group 5 multiple system disorder, like any system being affected, like either hematological or systemic disorders or metabolic disorders can cause pulmonary hypertension, right? So if you see this question now, pulmonary hypertension may occur in all of the following conditions except toxic oil syndrome, progressive systemic sclerosis, sickle cell anemia, Argemone mexicana poisoning, right? So you go back to the first question like what we were discussing and then come back to this, right? So if you see this question, pulmonary hypertension may occur in all of the following conditions except toxic oil syndrome, progressive systemic sclerosis, sickle cell anemia, and as well as the Argemone mexicana poisoning. So you take the progressive systemic sclerosis, right? It is a connective tissue disorder which will definitely cause the development of pulmonary arterial hypertension. So in systemic sclerosis you will have, and in certain anemias you have the development of the pulmonary hypertension, and anemia causing pulmonary arterial hypertension will be group 5 pulmonary arterial hypertension. And then toxic oil syndrome, that is rapeseed oil, this will contribute to group 1 pulmonary arterial hypertension, but whereas Argemone mexicana poisoning, that will not cause the pulmonary arterial hypertension. So these are all the etiologies of pulmonary arterial hypertension. Now after having discussed about the etiology, you see another important question. Pulmonary hypertension is caused by all except interstitial lung disease, myocardial infarction, systemic hypertension, thromboembolism. So interstitial lung disease will definitely cause pulmonary hypertension, that will be group 3. Myocardial infarction will cause left ventricular failure causing group 2 pulmonary arterial hypertension, and thromboembolism will cause pulmonary arterial hypertension, that will be group 4 pulmonary arterial hypertension, whereas systemic hypertension will not cause the pulmonary arterial hypertension, right? Next question is, all are the causes of pulmonary hypertension except hyperventilation, morbid obesity, high altitude, fenfluramine. So the one which will not cause pulmonary arterial hypertension here will be the hyperventilation. See, whenever the individual does hyperventilation, the individual will have hypocapnia, but oxygen levels will be normal, or the oxygen levels may be even increased. So when oxygen levels are adequate, there will not be development of pulmonary arterial hypertension. In fact, hypoxia right? In fact, hypoxia will cause the pulmonary arterial hypertension. Whereas morbid obesity, yes, it will cause obstructive sleep apnea causing pulmonary arterial hypertension. In high altitude, there will be hypoxia which will cause pulmonary artery vasoconstriction resulting in pulmonary arterial hypertension. And then fenfluramine. Fenfluramine is a drug which will cause group 1 pulmonary arterial hypertension. Okay. And the next important question is, pulmonary hypertension in COPD is due to dilatation of pulmonary vessels, hypoxia, interstitial fibrosis, bronchoconstriction. Let me tell you, in COPD, you have the development of the pulmonary hypertension. And what is the cause of pulmonary hypertension in patients with the COPD, right? So pulmonary hypertension is attributed to many factors in this condition of COPD. They are, number 1, hypoxic pulmonary vasoconstriction. Right? Number 2, the second important cause for the pulmonary hypertension in COPD patients is acidemia. And third, it is due to hypercapnia. Fourth, it is due to mechanical effects of high lung volume on pulmonary vessels. Right, mechanical effects of high lung volume on pulmonary vessels, because in patients with emphysema, like the lung, or in COPD, the lungs are like bulged, or the lungs are like distended, and it is irreversible distension, and this voluminous lungs, they can compress the pulmonary vessels causing pulmonary arterial hypertension. And the next important mechanism for the development of pulmonary hypertension in COPD patients is loss of small vessels in the vascular bed. Right, loss of small vessels in vascular bed. So these are the conditions, these are all the factors which will contribute to the development of pulmonary hypertension in COPD patients, right? So you see this question now. Pulmonary hypertension in COPD is due to hypoxia, right? And hypercapnia and acidemia and mechanical effects of high lung volume on the pulmonary vessels and loss of small vessels in the vascular bed. So these are the causes of pulmonary hypertension in COPD patients. Now let me discuss the other way by which we can classify the pulmonary arterial hypertension. So the question is, pre-capillary pulmonary arterial hypertension is defined as pulmonary arterial pressure more than 25 millimeters of mercury and pulmonary capillary wedge pressure more than 1 millimeter of mercury. Second option, pulmonary artery pressure more than or equal to 25 and pulmonary capillary wedge pressure less than or equal to 15. Third option, pulmonary capillary wedge pressure more than or equal to 25 and pulmonary artery pressure more than 15. And fourth option, pulmonary capillary wedge pressure more than or equal to 25 and pulmonary artery pressure less than or equal to 15 millimeters of mercury. So now what is this pre-capillary and as well as the post-capillary pulmonary arterial hypertension? So you see here, this is the 4-chambered heart, right side with the tricuspid valve and left side with the mitral valve. So we have the left atrium, then left ventricle, right atrium and then the right ventricle. From the right ventricle you have the pulmonary artery which is coming out and continues as the pulmonary capillaries in the lung, and then it continues as the pulmonary vein. So this will be pulmonary vein and this will be the pulmonary artery. So this is just an image to make you to understand, but this is how anatomy will not be there. So any pathology, now you see this is the capillary, okay, pulmonary capillary. So any pathology before this will be pre-capillary pulmonary hypertension, and any pathology after this will be post-capillary, right, will be post-capillary pulmonary arterial hypertension. So now let me just divide the etiologies into pre-capillary and as well as the post-capillary. What will be the characteristic features? So you take pulmonary hypertension as such. How much should be the pulmonary artery pressure? Pulmonary artery pressure should be more than or equal to 25 millimeters of mercury, right? And when you use the word pre-capillary pulmonary arterial hypertension, right, when you use the word pre-capillary pulmonary arterial hypertension, definitely either it is pre-capillary or whether it is the post-capillary, what should be there? The pulmonary arterial hypertension or pulmonary artery pressure should be more than or equal to 25 millimeters of mercury. There is no doubt in that. But what are the pre-capillary causes? So the pathology is at this point, that is at the level of the pulmonary artery and at the level of the lung, right? So what would be the pathology? That is pulmonary thromboembolism, right? PTE stands for pulmonary thromboembolism. And then pulmonary hypertension due to lung disease, right? Pulmonary hypertension due to lung disease or pulmonary hypertension of multifactorial mechanisms. So that will be your pre-capillary causes. And in pre-capillary, pulmonary artery pressure will be more than or equal to 25 millimeters of mercury, but pulmonary capillary wedge pressure, right? But pulmonary capillary wedge pressure, this pulmonary capillary wedge pressure will be less than 15 millimeters of mercury. That means there is no pathology in the left side of the heart here. In case of pre-capillary, there is no pathology in the left side of the heart. That is the reason why pulmonary capillary wedge pressure will be normal. Whereas you take the post-capillary. So if you take the post-capillary pulmonary hypertension, here also the pulmonary artery pressure should be more than 25 millimeters of mercury. But what will happen to pulmonary capillary wedge pressure? See, post-capillary pulmonary hypertension means this will be post-capillary. That is due to the left heart disease, right? That is due to left heart disease, where the pulmonary capillary wedge pressure, it will be more than 15 millimeters of mercury, because when there is mitral stenosis or when there is left ventricular failure, when there is mitral stenosis or when there is left ventricular failure, which is a left heart disease, the pulmonary capillary wedge pressure will be elevated. So pulmonary capillary wedge pressure more than 15 millimeters of mercury, this is considered to be the post-capillary pulmonary arterial hypertension. So what is the difference between these two now? In pre-capillary, pulmonary capillary wedge pressure will be normal, whereas in post-capillary, the pulmonary capillary wedge pressure is elevated. So you see this question now. Pre-capillary pulmonary arterial hypertension is defined as, that will be your second option, that is pulmonary arterial pressure will be more than or equal to 25 millimeters of mercury and pulmonary capillary wedge pressure will be less than or equal to 15 millimeters of mercury. That is what is nothing but your pre-capillary pulmonary arterial hypertension. Now, after having discussed about the etiologies, so what all we have discussed until now, let me just summarize in 1 minute. One, I have discussed the definition of pulmonary arterial hypertension, that is confirmed by your right heart catheterization, and it should be more than 25 millimeters of mercury. Then we have discussed 5 groups divided by WHO. Group 1, it is idiopathic or primary, or we have some systemic conditions. Then group 2, it is secondary to your heart disease. Group 3, secondary to lung pathology. Group 4, secondary to pulmonary thromboembolism. Group 5, right, it is again the multifactorial etiology, right? We have hematological disorders and we have some systemic diseases and some metabolic causes. And then we have classified the pulmonary arterial hypertension into pre and as well as post-capillary pulmonary arterial hypertension. Now, let me discuss what will be the symptomatology in patients with the pulmonary hypertension. So the question is, which of the following is not seen in primary pulmonary hypertension? Left parasternal heave, right parasternal heave, single S2, pulmonary ejection click. So if you take the signs and symptoms, now you take common to all the groups of pulmonary hypertension. You take group 1, group 2, group 3, group 4, group 5. Common to all the very important symptomatology is exertional dyspnea. Right, the very important symptomatology is exertional dyspnea, and other features include chest pain and as well as fatigue. So, and even lightheadedness. So, these are the features that you will see in the early stages of pulmonary arterial hypertension. Right, these are the features that you will see in early stages of pulmonary arterial hypertension. But as the severity progresses, right, as the severity of the disease progresses, the later symptoms include right, the later symptoms include syncopal attack, there can be abdominal distension, and followed by that there can be development of ascites causing abdominal distension, and next pedal edema. So these are the later symptoms, but these symptoms will develop, as the right ventricular dysfunction or right ventricular function, right, as the right ventricular function worsens, right, as the right ventricular function worsens, then you will see these particular later symptoms. But in early stages, it will be the exertional dyspnea, chest pain, fatigue, and as well as lightheadedness. These will be the early symptoms, right? These will be the early symptoms. Now, why is that they have this exertional dyspnea? See, whenever there is pulmonary arterial hypertension, let me tell you, the blood from the right ventricle is unable to enter into the lung. Because whenever there is pulmonary arterial hypertension, I'll just draw you an image here. Now, this will be your four-chambered heart. Right, this is the tricuspid valve, this is the mitral valve, and this is the pulmonary artery. So whenever there is pulmonary arterial hypertension, there is increased afterload on the right ventricle. So right ventricle is unable to send the blood into the pulmonary artery and pulmonary capillary. So oxygenation of the blood does not occur. Right, adequate amount of blood is not entering into the lung for oxygenation, and subsequently what will happen, there will be decreased amount of the blood which will be entering, decreased amount of oxygenated blood which will be entering into the left ventricle, resulting in the exertional dyspnea. So whenever the individual undergoes exertion, the cells require more and more oxygen. But here what is happening, the individual is unable to give an adequate cardiac output with oxygenated blood. Why? Because the blood from the right ventricle is not reaching the lung because of increase in pulmonary arterial hypertension and as well as increase in the afterload on the right ventricle. And the next important symptomatology is the chest pain and then fatigue. So why is that these individuals will have fatigue and as well as lightheadedness? Because the same scenario again. Now what is happening to the blood which is coming out of the left ventricle into the aorta? The quantity of the blood which is entering from the left ventricle to the aorta is reduced. Right? Why is it reduced? Because the blood coming from right ventricle into the pulmonary artery itself is reduced. That is the reason why the blood which is coming from left ventricle into the aorta is reduced. So thereby the cerebral perfusion reduces and perfusion to the organs reduces, and due to which they will have fatigue, lightheadedness, and they will also have the syncopal attack. And as the afterload on the right ventricle increases, subsequently there will be right heart failure. Right, there will be right heart failure, and once there is right heart failure, let me tell you, these individuals develop raised JVP, ascites causing abdominal distension, and then peripheral edema or the pedal edema. So these are the signs and symptoms of the pulmonary arterial hypertension. Next, followed by that, patients with idiopathic pulmonary arterial hypertension are characteristically young women who have evidence of right heart failure that is usually progressive, leading to death in 2 to 8 years without any therapy. Okay, so they progress into death in 2 to years, in 2 to 8 years if you are not giving any particular treatment. Now, you see, there is WHO functional classification of pulmonary arterial hypertension. Right? What is this WHO functional classification? We classify that into 4 classes, 1, 2, 3, 4. That is according to the severity of symptomatology. So in class 1, right, in class 1, patients with pulmonary hypertension but without resulting limitation of physical activity. Right? There is no right, there is no limitation of the physical activity in class 1. So ordinary activity, right, ordinary physical activity does not cause fatigue. Right, does not cause fatigue, does not cause dyspnea, right, and does not cause the syncopal attack. Right, ordinary activity does not cause fatigue, dyspnea or syncopal attack. Whereas you take class 2. Class 2, these patients with pulmonary hypertension resulting in slight limitation of the physical activity. Right, slight limitation of the physical activity. So, you know, these patients, right, these patients, they are comfortable at rest. Right, these patients, they are comfortable at rest. And when you do an ordinary physical activity, right, but when the individual does ordinary physical activity, this results in, right, this results in an undue fatigue, dyspnea, and they also have the chest pain and even the syncopal attack. Right, even the syncopal attack. So this will be your class 2 pulmonary arterial hypertension. Right, so class 2 pulmonary arterial hypertension is that these patients, they are comfortable at rest, but there will be slight limitation of the physical activity whenever the individual does exertion. Whereas in class 1, there is no limitation of the physical activity at all. But these individuals upon exertion, that is class 2, upon exertion, they have slight discomfort or slight limitation of the physical activity. Whereas you take class 3. Class 3, these patients with pulmonary arterial hypertension results in marked limitation of the physical activity. Right, there is marked limitation of the physical activity and less than ordinary activity. Right, with less than ordinary activity, these individuals will have fatigue, dyspnea, chest pain and heart syncope. Whereas in class 2, they are comfortable at rest, but when they do ordinary activity, they will have fatigue, dyspnea, chest pain and syncopal attack. But whereas here, less than ordinary activity, they will have all these manifestations. Then you take class 4. Class 4 pulmonary arterial hypertension, these individuals they are unable to carry out any physical activity without symptoms. Right, unable to carry out any physical activity without symptoms. That means these individuals, they become symptomatic at rest. Right, they have dyspnea at rest, and in fact the discomfort increases upon physical activity. So that is about your WHO functional classification of pulmonary hypertension, class 1, class 2, class 3 and class 4. Then what will be the signs of pulmonary hypertension? See, in patients with pulmonary hypertension, there is increased afterload on the right ventricle. Right, there is increased afterload on the right ventricle. So there will be right ventricular hypertrophy. Right, there will be development of right ventricular hypertrophy. So once there is development of right ventricular hypertrophy, when you palpate, there will be left parasternal heave. Right, due to right ventricular hypertrophy, there will be left parasternal heave, and they will have single S2. Why? Because these patients, they will have loud P2. Because of loud P2, you will hear the S2 as a single sound. Why there is loud P2? That is because of your pulmonary arterial hypertension. And these patients, they have a functional murmur. Right, these patients, they have the functional murmur, and this particular functional murmur is Graham-Steele murmur. Right, this particular functional murmur will be the Graham-Steele's murmur. So what is this Graham-Steele's murmur? So whenever there is development of pulmonary hypertension, right, whenever there is development of pulmonary hypertension, that increased pulmonary artery pressure will cause the blood to leak. Right, that increased pulmonary artery pressure will cause the blood to leak from the pulmonary artery into the right ventricle. Right, it will cause the blood to leak from the pulmonary artery into the right ventricle, and that will result in what is called pulmonary regurgitation. Right, that will result in what is called pulmonary regurgitation, and this pulmonary regurgitation murmur will be an early diastolic murmur. Right, this pulmonary regurgitation murmur will be early diastolic murmur, and that is nothing but your Graham-Steele's murmur. Okay, so these are the signs of pulmonary hypertension: left parasternal heave, loud P2 due to which the second heart sound is heard as a single sound, and there will be Graham-Steele's murmur, and these patients, they also have the pulmonary ejection click. Right, pulmonary ejection click. So these are the signs of pulmonary hypertension. So if you see this question now, which of the following is not seen in primary pulmonary hypertension? Left parasternal heave, right parasternal heave, single S2 and pulmonary ejection click. They will not have right parasternal heave. What they have is left parasternal heave. And why is that? That is due to right ventricular hypertrophy. You have this left parasternal heave. Okay, now coming on to the diagnostic criteria in pulmonary hypertension. See, the definitive diagnosis of pulmonary hypertension requires right heart catheterization. Right, the definitive diagnosis require the right heart catheterization. And here, the right heart catheterization will show you that mean pulmonary artery pressure is more than 25 millimeters of mercury at rest. Right, more than 25 millimeters of mercury at rest. And the next important thing is this catheterization allows the measurement of pulmonary pressures and testing for vasoreactivity using a variety of agents. Right, when we are doing right heart catheterization, we need to do the vasoreactivity test. Why we have to do the vasoreactivity test, I will tell you. But what is the preferred agent for doing the vasoreactivity test? The preferred agent is the nitric oxide. Okay, why? Why we should prefer nitric oxide? Because it has a short half-life. Immediately the action of the nitric oxide will disappear. Now, what is the importance of this vasoreactivity test? See, whenever you inject nitric oxide, there should be fall in the pulmonary artery pressure. Right? So when will you consider it to be a positive response? A positive response is defined as one that decreases the pulmonary artery pressure by greater than, right, by greater than 10 millimeters of mercury, with the final mean pulmonary arterial pressure less than 40 millimeters of mercury. So that means, see, what I am trying to tell you is, what is the purpose of this vasoreactivity test? It will tell us to give what type of drugs in the treatment of pulmonary arterial hypertension. The treatment part I will tell you. So, but until now what you have to understand and what is the use of this vasoreactivity test, whenever you give nitric oxide, if the mean pulmonary artery pressure reduces by more than 10 millimeters of mercury, that we consider it to be a positive response. Right? That is considered to be a positive response. Okay? Now, what is the importance of this positive response? I will discuss subsequently. But the definitive diagnosis of your pulmonary arterial hypertension is done by right heart catheterization. And the other investigations are the chest radiography and as well as 2D echo and ECG. Because your right heart catheterization is an invasive procedure. We don't do invasive procedure in all the patients because it is an expensive, right? And it requires hospitalization, and it can also cause the iatrogenic injuries. So usually we avoid, because when we have other investigations to diagnose pulmonary arterial hypertension, we directly don't go to the right heart catheterization. Right heart catheterization will be definitely a definitive diagnosis, but first line investigation will be 2D echo. 2D echo will tell you whether the pulmonary artery pressure is increased or not. Okay, next. So coming to the chest radiograph. So the chest radiograph of a patient with pulmonary arterial hypertension shows enlargement of central pulmonary arteries. Right, enlargement of the central pulmonary arteries with attenuation of the peripheral vessels. Right, with attenuation of the peripheral vessels. And because of the attenuation of the peripheral vessels, that will result in the oligemic lung fields. Right, that will result in the oligemic lung fields. Okay, so that is one chest X-ray finding, that is enlargement of the central pulmonary arteries with attenuation of the peripheral vessels resulting in oligemic lung fields. And second important thing is, there will be right ventricular hypertrophy or right ventricular enlargement. Okay, right ventricular enlargement. So how can you make out that there is right ventricular enlargement? That is, when you take the lateral view of the chest X-ray, right, when you take the lateral view of the chest X-ray, lateral view of the chest X-ray shows diminished retrosternal space. right, will show diminished retrosternal space. So that is how you will be able to make out that there is right ventricular enlargement. So that will be the chest X-ray findings. So number one, there will be enlargement of central pulmonary arteries with attenuation of the peripheral vessels resulting in oligemic lung fields. And number two, there will be right ventricular enlargement where you have diminished retrosternal space on the lateral view of the chest X-ray. Then what are the, yes, so this is a normal chest X-ray, right, where you don't have the prominent, right, you don't have the prominent right parasternal area of the cardiac shadow. But you see, in pulmonary hypertension, you can make out that there is enlargement of the pulmonary arteries, right, and you can make out that there is peripheral hypovascularity, okay, and in the lateral view of the chest X-ray, you can see that retrosternal space is obliterated. Okay, retrosternal space is obliterated. So that is what will be the chest X-ray findings in patients with the pulmonary arterial hypertension. Then followed by that, the ECG in patients with the pulmonary arterial hypertension. So primary pulmonary arterial hypertension has the following features on ECG except sinus tachycardia, ST segment elevation, increased P wave amplitude, the right axis deviation. So let me discuss the ECG and then come back to this question. So if you take the signs of right ventricular hypertrophy, what will be there on the ECG? First I will tell you all the signs, then I will show you the ECG. Number one, you have the features of the right axis deviation, right? You have the features of right axis deviation, right? How is that you will be able to make out that there is right axis deviation? That is by the presence of dominant R wave in V1, right? That is how you can tell that there is right axis deviation. And the other method is by, in lead 1 you have a negative QRS complex, and lead 2 you have a positive QRS complex. So this is how you can make out that there is right axis deviation. Negative QRS complex in lead 1 and positive QRS complex in lead 2. And the other features of right ventricular hypertrophy or right ventricular strain is the development of right bundle branch block. Either there is incomplete or complete right bundle branch block. T wave inversion will be there. And this T wave inversion, let me tell you, it is asymmetrical T wave inversion in the right sided leads. And there will be development of sinus tachycardia. So these will be the ECG changes that you will see in patients with the pulmonary arterial hypertension secondary to right ventricular hypertrophy. Now, so you see this will be the ECG, right? You see dominant R wave in lead V1, right? And you have the negative complex in lead 1 and positive complex in lead 2. So lead 1 and lead 2 will be meeting together. That is a sign of right axis deviation. And the other important thing is the T wave, right? This is called strained T wave. Right? This is called strained T wave, where you have asymmetric T wave inversion. Right? What do you mean by the word asymmetric T wave inversion? That is, the morphology of the T wave will be like this. Right? The two limbs of the T wave will not be symmetrical. There will be asymmetrical T wave inversion. Right? Then, so this will be the ECG changes in patients with the pulmonary arterial hypertension. And so let me tell you, in patients with the pulmonary arterial hypertension, ECG will not show the ST segment elevation. Right? ECG will not show the ST segment elevation. Whereas sinus tachycardia will be there, because in patients with the pulmonary hypertension, they have significant hypotension. And because of hypotension, secondary to this hypotension, what will happen to the heart rate of the individual? It increases. and that will be represented on the ECG in the form of sinus tachycardia. And there will be also increased P wave amplitude. Why is that? Because of the right atrial enlargement. See, once there is right ventricular hypertrophy, right atrium, it requires more pressure to send the blood into right ventricle. So right atrial hypertrophy will be there, and due to which there will be increased P wave amplitude, and this we call it as P pulmonale. Right? So this will be the ECG changes in patients with the pulmonary hypertension. Then followed by that echocardiography. Echocardiography, this will be the first line investigation in patients with the pulmonary hypertension. And this echocardiography shows, number one, right ventricular hypertrophy. Then there is right atrial enlargement or right atrial dilatation will be there. Then there will be functional tricuspid regurgitation and functional pulmonary regurgitation will be there in the echocardiography, right? And there will be flattening of interventricular septum during systole. Right? Flattening of interventricular septum during systole. So this will be the echocardiographic findings in patients with the pulmonary hypertension. Next, followed by that, what will be the pulmonary function test in patients with the pulmonary hypertension? See, the pulmonary function test in these individuals will diagnose if there is any lung pathology causing pulmonary hypertension. Right? It will diagnose if there is any lung pathology causing the pulmonary hypertension. For example, COPD causing pulmonary hypertension. What will be there? There will be an obstructive pattern, right? There will be an obstructive pattern in the pulmonary function test, and you take DLCO, that is diffusion capacity of the lung for carbon monoxide. Diffusion capacity of the lung for carbon monoxide is reduced. Okay, so this will be the pulmonary function test. Then what does the CT scan shows? The chest CT demonstrates enlarged pulmonary arteries. Right, it demonstrates enlarged pulmonary arteries and excludes the other causes. Right, that means it will exclude if there is any presence of interstitial lung disease. It will exclude if there is any presence of the emphysema. Then followed by that, the pulmonary angiography. See, pulmonary angiography reveals the loss of small acinar pulmonary vessels. Right, reveals loss of small acinar pulmonary vessels. Right, and there will be tapering of there will be tapering of the larger ones. So that will be the pulmonary angiography in patients with the pulmonary hypertension. So if you take the first line investigation, that will be 2D echo. Confirmatory investigation will be right heart catheterization, and then the other investigations are the ECG, chest X-ray, pulmonary function test, and then pulmonary angiography. Right? Now, followed by that, let me discuss the treatment in patients with the pulmonary hypertension. So, if you see the treatment of pulmonary arterial hypertension, the question is, all of the following are used for treating pulmonary hypertension except endothelin receptor antagonist, phosphodiesterase inhibitors, calcium channel blockers, and then the beta blockers. Okay. Now, so when I was discussing the right heart catheterization, there I was telling you about the vasoreactivity test. Now, I will use that particular concept of vasoreactivity here. See, treatment of pulmonary hypertension begins with the assessment of the disease severity followed by the primary therapy. Right? You need to assess the disease severity followed by the primary therapy. And primary therapy is directed at underlying, right? It is directed at the underlying cause of the pulmonary hypertension. right? Whatever is the underlying cause, the primary therapy is directed accordingly. Some patients progress to advanced therapy, which is the therapy directed at pulmonary hypertension itself rather than the underlying cause. Now, what is this primary therapy and what is this advanced therapy? Primary therapy is that you treat the underlying cause. Like for example, left heart failure is causing pulmonary arterial hypertension. You treat that. Lung pathology is COPD is causing pulmonary hypertension. You treat that COPD. That will be your primary therapy. Whereas advanced therapy means you will dilate the pulmonary artery, right? You will dilate the pulmonary artery, thereby decreasing the pulmonary artery pressure. That will be the advanced therapy. So now let me discuss about the primary therapy first. So primary therapy refers to the treatment that is directed at the underlying cause of pulmonary hypertension, and it is warranted in nearly all patients with pulmonary hypertension. Right? It is warranted in nearly all patients with pulmonary hypertension. And the disease severity should be reassessed following the primary therapy in order to determine whether advanced therapy is indicated or not. So what you have to do is, even after giving the primary therapy, right, after giving the primary therapy, the disease severity should be reassessed following the primary therapy in order to determine whether the advanced therapy is indicated or not. Okay. Once you treat the underlying cause and when the pulmonary artery pressure is reducing, well and fine. And if the pulmonary artery pressure is not reducing, then you have to, right, then you have to give advanced therapy to the individual. Right, then you have to give advanced therapy. Right, then you have to give advanced therapy that is being indicated. Now, you take the primary therapy. What does the primary therapy consists of? The primary therapy, right, primary therapy of pulmonary hypertension, it consists of, right, it consists of diuretics, right, and in which group of pulmonary artery hypertension you require to give the diuretics? That is in group 2 pulmonary hypertension, where the etiology is either mitral stenosis or the etiology is the left ventricular failure. So when the etiology is mitral stenosis or left ventricular failure, that can make the individual to develop the pulmonary arterial hypertension, and the individual will also develop pulmonary edema. So in order to reduce that pulmonary venous pressure, in order to reduce that pulmonary edema, you can give diuretics, right? And the diuretics that we give is the loop diuretics. Right? The diuretics that you need to give is the loop diuretics, right? And apart from the loop diuretics, for suppose, if the individual has developed bowel edema, because in patients with right heart failure, there will be congestive hepatomegaly, portal hypertension, and there will be bowel edema. So when there is bowel edema, you know, loop diuretics cannot be absorbed. So when there is bowel edema, you need to give torsemide and as well as the bumetanide. Right, torsemide and as well as the bumetanide. So these are the diuretics that you need to give if there is presence of bowel edema. Right, if there is bowel edema. Okay, and second important thing is the oxygen therapy. Right, oxygen therapy. See, oxygen therapy should be used to maintain the oxygen saturation more than 90%. Right, oxygen saturation should be maintained more than 90%. Okay, and oxygen therapy is mainly required in patients with mainly in patients with group 3 pulmonary arterial hypertension. So what is group 3 pulmonary arterial hypertension? It is secondary to lung pathology. Right, it is secondary to lung pathology where you have to give the oxygen therapy, because when there is lung pathology, the individual will have hypoxia, And whenever there is hypoxia, the individual will have pulmonary arterial vasoconstriction causing pulmonary arterial hypertension, causing the right ventricular hypertrophy and right ventricular failure. So you need to give oxygen therapy in patients with the group 3 pulmonary arterial hypertension. And the other form of primary therapy is the other form of primary therapy is the anticoagulation. So what is the anticoagulation that you give? Either warfarin or the low molecular weight heparin. This should be given in case of this should be given in case of group 4 pulmonary arterial hypertension. So in case of group 4 pulmonary arterial hypertension, which is secondary to pulmonary thromboembolism, in them you need to give the anticoagulants. So this will be your primary therapy. Primary therapy means you need to treat the underlying cause. And another drug in the primary therapy is supplementing the digoxin. See, supplementing the digoxin, please make a small correction here. This entire thing should not be there. Just please apply a white patch at this point. Okay, this is the instruction to the editors. Now, you take the digoxin. Digoxin is also the part of the primary therapy, and that is given in patients with left ventricular failure. That is given in patients with left ventricular failure. So, left ventricular failure, you know, it will be the etiology causing group 2 pulmonary arterial hypertension. It will be the etiology causing group 2 pulmonary arterial hypertension. Okay. So, primary therapy means you need to treat the underlying cause. Then, coming to the advanced therapy. Now, what is this advanced therapy? Advanced therapy, it is specifically directed at dilating the pulmonary artery. Specifically directed at dilating the pulmonary artery and reducing the pulmonary arterial hypertension. And reducing the pulmonary arterial hypertension. So that will be the advanced therapy. This will be the advanced therapy. Now, in which group of individuals you need to give this advanced therapy? So, if you see the indications of the advanced therapy, in group 1 pulmonary arterial hypertension, the advanced therapy, it is widely accepted. Whereas group 2, it will be your primary therapy, where you need to treat the underlying cause, that is left ventricular failure or mitral stenosis. Then group 4 and group 5, mainly they require the primary therapy. Mainly they require the primary therapy. Which one? Group 3 and group 4. That is your treatment of lung pathology and treatment of chronic pulmonary thromboembolism. Whereas group 5, they require the advanced therapy again. So what is advanced therapy? It is the one which is directed against reducing the pulmonary artery pressure by causing the pulmonary artery dilatation. Next, followed by that, now let me discuss about the vasoreactivity testing and right heart catheterization. The same I was discussing in the diagnosis. So what is this vasoreactivity testing? You need to give nitric oxide. You need to give nitric oxide. When you give nitric oxide, the pulmonary artery pressure should fall by more than the pulmonary artery pressure should fall by more than 10 millimeters of mercury. This is called positive vasoreactivity testing. So, in these patients, in these patients where there is positive vasoreactivity testing, in these patients with positive vasoreactivity testing, you need to give the calcium channel blockers. You need to give calcium channel blockers for the treatment of pulmonary arterial hypertension. That is in those individuals who have positive vasoreactivity testing, right? And in those individuals, right, whenever you are giving calcium channel blockers, if the patient responds to calcium channel blockers, they should be reassessed after 3 to 6 months of treatment. Right, they should be reassessed after 3 to 6 months of the treatment. And those individuals who have negative vasoreactivity, that means, for example, you are giving calcium channel blockers, but there is no decrease in pulmonary artery pressure, or in those individuals where there is negative vasoreactivity, that means only in those individuals who have positive vasoreactivity, in them you need to give the pulmonary artery vasodilators like calcium channel blockers. And in those individuals who have negative vasoreactivity or who does not respond to calcium channel blockers in spite of positive vasoreactivity, in them you need to give non-calcium channel blocker agents. Right, in them you need to give non-calcium channel blocker agents. That is a very, very important point that you need to remember. So I'll repeat again. What is vasoreactivity test? Whenever you are doing right heart catheterization, you need to inject nitric oxide into the pulmonary artery. Whenever the pulmonary artery pressure decreases by more than 10 millimeters of mercury, that is called positive vasoreactivity testing. And in those individuals who have positive vasoreactivity testing, you need to give calcium channel blockers. Right, and whenever you give this calcium channel blockers, if the pulmonary artery pressure is decreasing, well and fine. But if the pulmonary artery pressure is not decreasing, then you need to give non-calcium channel blocker agents. And the next point is, for suppose if there is negative vasoreactivity testing, even them you need to give non-calcium channel blocker agents. Okay, so now what are these non-calcium channel blocker agents? We will discuss now. So you see this question, all are used in the treatment of pulmonary hypertension except your endothelin receptor antagonist and phosphodiesterase inhibitors. Both of them, they are non-calcium channel blocker agents. And even calcium channel blockers are given in the treatment of pulmonary hypertension, but the beta blockers, right? But the beta blockers, they have no role in the treatment of pulmonary hypertension. Please remember, beta blockers are not used. Now, let me discuss in detail about the non-calcium channel blocker agents. So this non-calcium channel blocker agents, that includes the prostanoids, and these prostanoids include intravenous epoprostenol, right, intravenous epoprostenol. Then second, we have intravenous treprostinil. Third, this intravenous treprostinil or treprostinil can be given through subcutaneous route as well, and this treprostinil can be given through inhalational route as well, right? And the another drug what we have is the iloprost, and this iloprost, it is given through the inhaled route. Right, it is given through inhaled route. These are the prostanoids: epoprostenol, treprostinil, then iloprost. Right, then you take endothelin receptor antagonist. Endothelin receptor antagonist examples like what we have is bosentan, ambrisentan, then sitaxanton, right, sitaxanton. See, these are all your endothelin receptor antagonists. which are your non-calcium channel blocker agents. Then phosphodiesterase inhibitors that can be given includes sildenafil, then we have tadalafil, and third vardenafil. Okay, so these are the phosphodiesterase inhibitors, which are non-calcium channel blocker agents. And apart from that, we have some new agents as well, that is guanylate cyclase stimulator, that is riociguat, then selexipag. So the next we have the prostacyclin receptor agonist, right? So that will be your selexipag. So we have two groups of new molecule, that is guanylate cyclase stimulator, that is riociguat, and as well as prostacyclin receptor agonist, that is selexipag. So these are the drugs which are non-calcium channel blocker agents, right? And apart from that, counseling and patient education is very important, right? Aerobic exercises is recommended, but no heavy physical exertion or isometric exercises. Only aerobic exercises, they are recommended. And routine immunizations, they are advised, right? Routine immunizations, they are advised. And let me tell you regarding the pregnancy. See, pregnancy should be strongly discouraged, and preventive measures may be taken or should be taken to ensure that pregnancy does not occur, right? And you know, in severe pulmonary arterial hypertension, maternal mortality rate is up to 50%, right? So pregnancy should be strongly discouraged, right? That is about the treatment in case of the pulmonary arterial hypertension. So you take the entire summary of your pulmonary arterial hypertension. In patients with the pulmonary arterial hypertension, pulmonary artery pressure is more than 25 millimeters of mercury. And these individuals, we have 5 groups. One is your idiopathic or primary, that is group 1. Then left heart failure or left-sided pathology, lung pathology, then pulmonary arterial pathology, and then multifactorial mechanisms. So these are your 5 pathologies, right? And then the clinical features, mainly they will have dyspnea. They can also have syncopal attack. And on examination, you will have loud P2 and then left parasternal heave. And then the investigations, if you take, first line investigation will be 2D echo, and confirmatory investigation will be right heart catheterization. And treatment, primary therapy, treat the underlying cause. Whereas advanced therapy, you need to give non-calcium channel blocker agents, right? Initially, you need to give calcium channel blockers, that is the one which will reduce the pulmonary artery pressure. But if the patient is not responding, then you need to give non-calcium channel blocker agents, right? And we also have a new molecule, and these new molecules are guanylate cyclase stimulator, that is riociguat, and then prostacyclin receptor agonist, that is the selexipag. Okay, so and you see another question here. Iloprost used in pulmonary hypertension. Iloprost, let me tell you, I for iloprost, I for inhalational route. And next question, drug not used in pulmonary hypertension. Calcium channel blockers, endothelin receptor antagonist, alpha blocker, then prostacyclin. So alpha blockers, let me tell you, they are not used for pulmonary hypertension. And you take one more clinical scenario. A 34-year-old woman with a diagnosis of primary pulmonary hypertension returns for evaluation. She has had a progressive increase in her dyspnea over the past 6 months. She has had marked fatigue for past 4 months. Last month, she developed hoarseness. Evaluation by otolaryngologist led to a diagnosis of the Ortner syndrome. 1 week ago, she had onset of chest pain and episode of the syncopal attack. Of the symptoms this patient had, which of the following symptoms suggest the worst prognosis? Chest pain, dyspnea, fatigue, syncope, and as well as the hoarseness. Let me tell you, all of the symptoms which are listed are associated with the pulmonary hypertension. These are all seen in patients with the pulmonary arterial hypertension. But this syncopal attack, it occurs later in the course of the illness. And if there is syncopal attack, that tells you poor prognosis. Right? That tells you poor prognosis. Okay. And what is this Ortner syndrome, and why does this Ortner syndrome occur? You know, this particular Ortner syndrome occurs whenever the dilated pulmonary artery, whenever it compresses the recurrent laryngeal nerve. right, whenever it compresses the recurrent laryngeal nerve, that will cause the recurrent laryngeal nerve palsy, and that is called the Ortner syndrome, right? That is called the Ortner syndrome. Okay, so and out of all these, the symptoms of pulmonary arterial hypertension, the syncopal attack is the later stage disease. So if the syncopal attack is there, then the individual has very, very poor prognosis, right? And you see the next clinical question. A 32-year-old man comes to your office for a job-related injury, right? His family history is remarkable for two relatives who had internal bleeding in their 40s. On examination, you notice multiple small telangiectasias on his lips, skin, and as well as the oral mucosa. His fingernails appear slightly clubbed. The chest X-ray reveals several small, perfectly round nodules in both the lungs. Which of the following is the most accurate statement about this patient's condition? He is likely to develop pulmonary hypertension and right heart failure. He has increased risk of stroke and brain abscess. His pulmonary function test will show significant restrictive disease. There is no need to consider treatment if he remains asymptomatic. So, which of the following is most accurate statement about this patient's condition? So, the answer here is his pulmonary function test will show significant restrictive disease. Now, why? Because in this disorder, there are often numerous arteriovenous malformations in the lung. And how is that you are telling that there is numerous arteriovenous malformations in the lung? Because this particular patient is having, like small nodules in both the lungs. And there are small telangiectasias that are present over the lips, skin, and as well as the oral mucosa. So, such patients, they have an artificially low pulmonary resistance because of substantial fraction of the blood may shunting through the arteriovenous malformation. So, because of the arteriovenous malformations within the lung, his pulmonary function test will show significant restrictive disease, right? So, this is about the questions related to pulmonary arterial hypertension. So, this completes the discussion on this very important topic, that is pulmonary arterial hypertension. Thank you very much.